الاجيال بتاعتنا كانت دايما حاسه ان احنا لاجينج بيهايند، وان المفروض ان احنا ناخد opportunities اكتر واكتر، ويبقى في environment يساعد على ان الواحد يبقى في teaching ويبقى في development of new techniques وapplications. فيعني بنشوفه يعني جدا، وبشكركم طبعا على الحضور. هو انا يعني التوبيك هو الام ار نيوروجرافي نيو انسبايرنج بلاتفورم. هو انا اخترت التوبيك ده الحقيقه لانه over the past 2 years we have received about 53 cases of MR neurography. The patient is coming from the clinician with this request, MR neurography. There is an increased demand and an increased knowledge at the level of the clinicians about this study. It's not a new study, but the idea is that unfortunately during these 2 years, the majority of cases came with gunshot injuries. And then the second common causes are the pain, the neurogenic pain that is not explained clinically, or there is a suspicion clinically and the clinician cannot pinpoint the site of involvement. So it's important for the management of the patient to pinpoint where the abnormality is, either by exclusion, it's not there, or by establishment of the diagnosis that this is actually a neurogenic condition. Evaluation of the peripheral neuropathies has traditionally been relying on clinical examination and electrodiagnostic testing. But then there are settings where symptomatology is not explained by these means, or when management relies on the accurate localization of the level of neural affection. لأن دلوقتي بقى فيه اللي هو الجايدنس اللي هو guided therapies اللي هي البلوكج للنيرفز واللي هي البين تريتمنت والبين ثيرابي اللي هي بتبقى regional related to this nerve and its supply, and precisely delineating the cause of this symptomatology. Now, this is an example of a case at first. This patient, any of these are 3 different patients who are presented with shoulder pain, or we can say a right neck-based pain. There are different causes of this pain. The first case here is a brachial neuritis. I'm going to show you in details and in depth what's the difference between them and how to interpret the MR neurography, but this is just a glimpse of how to we tackle and how we use this technique. This is a brachial case of brachial neuritis. There is accentuated, this is a stair sequence, there is accentuated right signal and enlargement of the right brachial plexus selective nerves. This is a case of a malignant nerve sheath tumor, where you can see it is related and implicating the course of the nerve. And then this is an ugly infiltrative mass lesion, it's a pancreas tumor, with giving rise to the same clinical symptomatology of the patient. Now, the idea of MR neurography is based on using MR tools or sequences which are sensitive to the water content, neuronal water content. So actually the nerve is composed of about 80% water. Now this water is seen within the nerve, in between the fascicles, within the endoneurium, within the internal epineurium. So according to this, the integrity of this water content, we verify the integrity of the nerve. MR neurography is becoming more and more appealing because it nicely delineates peripheral nerve anatomy and pathology. So as we can see here, this one here is the normal lumbosacral plexus. Of course, this is a cut, coronal cut. It's not demonstrating the whole lumbosacral plexus. I'm going to show you the TICS-LAB MIP, which Dr. Wahid was talking about for the intrography. It works excellently here, and I actually like it very much. It's my favorite sequence and my favorite technique of interpretation. Then we've got here, this is a case where if we are comparing here the signal intensity and the caliber of the right sciatic nerve, this definitely is larger and with inhomogeneous bright signal. This is a case of a peri-neuroma. Furthermore, there is the MRI is superior because it helps in the individual delineation and assessment of the nerve fiber, starting by the root, the ganglion, and the nerve itself, individually assessing it through targeted and specifically oriented slices and sections. Now, the role of MR neurography, it provides important information that may assist in the diagnostic and therapeutic workup of peripheral nerve lesions through localization of the peripheral nerve lesion, assessment of the extent of abnormality in nerve injuries and disease load in diffuse peripheral nerve lesions such as in hereditary neuropathies and in neurofibromatosis, together with in detecting the causes of nerve entrapment and impingement. Furthermore, it also defines the extent of nerve injury, and it helps in the detection of other incidental findings at the region of interest, and to provide imaging guidance for perineural medication injections, together with the follow-up of the course of nerve regeneration. Now, I'm going to talk about the dedicated MR Neurography Protocol, but then I have to say any musculoskeletal MR study could interpret a regional nerve, because it's based on a fat of a T2 weighted sequence, preferably طبعا هتبقى T2 fat suppressed sequence. فaccording this is integrated in any musculoskeletal protocol. A targeted or a dedicated MR neurographic protocol is applied for the major nerves like the lumbosacral plexus and the brachial plexus, while the peripheral nerves, they are assessed according to their region and according to their abnormal anatomical locations. This is important because a patient can come with a certain symptomatology and he does a certain study, let's say a knee MRI, and he has an element of, he gives a history of trauma, and all what we're looking for in the knee is the myocontusion, the ligamentous sprain, the tendinous and the muscular strains. But then there is another point, which is the nerve, the adjacent nerves. We've got the posterior tibial nerve, the common perineal nerve, which could be affected and could be a main cause of symptomatology in the patient rather than the knee condition, direct knee condition. So this is of major importance because when reporting a simple MRI of the knee, you can detect other additional findings that are of major importance to the patient. So in an tailored MR neurographic protocol, we use high-resolution T1 and anatomical T1 and T2 weighted images, 3D stair sequence with the acquisition of thick big slabs, T2 weighted sphere sequence, Dixon sequence, which is a water-sensitive sequence, diffused WIPS and diffusion weighted imaging. The idea is that WIPS helps in the delineation of the nerve, and in the assessment of the integrity of the nerve. Is there a cut, is there an injury to the nerve, and the different degrees which we are going to discuss later on. But we don't quantify the ADC through a WIPS sequence. We have to do another DWI sequence to be able to quantify the ADC, which helps in the follow-up of nerve regeneration. We're going to see also later on. And then we got the post-contrast T1 weighted fat suppressed images and DTI, which is not a routine, but it has its role and it has its applications. Now the normal lumbosacral plexus, we all know the normal lumbosacral plexus through diagrams and through the dissection. But then on MRI, we've got the T2 weighted sequence, coronal, the T1 weighted sequence, and then we've got the stair. The idea is that the orientation of these slices is a bit, it goes tangential to the posterior aspect of the lumbosacral, it goes tangential parallel to the lumbosacral junction. Okay, this angle here, or this curve here, it goes more or less parallel to it to take the orientation of the lumbosacral plexus and the proximal part of the sciatic nerve, which is here. Okay. Of course, there are multiple images. We cannot see the nerve or the lumbosacral plexus as a whole in a single image. It's only appreciated on the thick slab MIPS, which I'm going to show you later on. Then this is a Dixon sequence, which is a water-sensitive sequence. It is very nice in the delineation of the nerves, the ganglia, the nerves, the course of the nerve, and it suppresses the fat planes, the surrounding fat planes, so it flares out the course of the nerve amidst the muscle and the intermuscular fascial planes or fat planes. There is also the 3D stair sequence where we can take different orientations according to the need in each patient to visualize the lumbosacral plexus coronally or obliquely, or with selected views for different or highly selective views for certain nerve roots and nerve fibers. Then we take the axial, they are axial oblique, they are, normally we take the axial, the normal axial images over the pelvis and the upper thigh, but then it has been advocated if we are doing a tailored MR neurographic study, it is preferable to follow the course of the sciatic nerve. Here I'm talking about the sciatic nerve, so we are taking it perpendicular to the course of the sciatic nerve to better visualize it. Okay, and to better visualize it at the interfaces between, at the muscular interfaces, like here, this is the normal sciatic nerve at this level, and then the normal sciatic within the nerve within the thigh, with a clear surrounding fat planes. Then we've got the diffusion weighted images. Now the neural structures are normally restricting organs, starting with the brain, the cord, and the peripheral nerves. So this is the use of the DWIPS sequence. This is a DWIPS sequence. It's very nice to suppress. It's DWIPS stands for the diffusion weighted imaging with background signal suppression. The background signal suppression helps to better detect the course of the nerve and to better detect injury. If we are talking about a severing of the nerve or a transection of the nerve, it is better delineated in this through this sequence. And then we got the DTI and the tractometer. Now this is this is supposed to be a video.
دراج الفيديو في نفس الفولدر عشان يشتغل. هو فين الفيديو ده؟
طيب هو المفروض ان ده الفيديو ده عشان ابين الكورس وهو ماشي، يعني هو انا المفروض ان هو ده ستير سيكونس بيتاخد تيك سلاب ميب عليه عشان اخد كل الجزء بتاع الريجن اوف كونسيرن. المفروض ان هو بعمل تراكنج للنيرف فايبرز من اول بدايتها لغايه الكورس، انتهاء الكورس في الريجن اللي انا مغطياه. احنا بنعمله انفيرتد عشان برضو نفس فكره الدويبس ان هو better delineation of the structure with the suppression of the signal from the surrounding tissues. ده برضو كان post contrast برضو في الفيديو، معلش. بعد كده في اللي هي النورمال brachial plexus. برضو this is the normal brachial plexus we know from the diagrams and the dissection. Here is how it appears on the MRI. We've got the T2 weighted image, the normal pattern of the brachial plexus from the roots, and then we've got the trunks, the fibers, the divisions, and which can be demonstrated. Then we've got, this is again a 3D stair sequence, DWIPS sequence, and the DTI. Now, what to expect in an MR neurographic study? Now, there are points we have to know to differentiate between a normal nerve and an abnormal nerve. These points include the size of the nerve, the signal intensity, the fascicular pattern, and we can see the fascicular pattern. It needs just magnified views and a high resolution sequences to demonstrate them, and the course together with the enhancement pattern together with the perineural fat plane. So when we are reporting an MR neurographic study, we have to tackle all these points as regards the nerve of concern. Now there's an important terminology that we must know when we are dealing with an MR neurographic study. Nerve injuries are graded on the basis of severity into neuropraxia, axonotmesis, and neurotmesis. Of course, the degree of discrimination between axonotmesis and neuropraxia is somewhat difficult, but in some cases you can differentiate between them. Of course, in neurotmesis there is severing of the nerve, so it's disrupted either totally, or you will find there's a neuroma replacing the disrupted nerve fibers. So in this diagram we can see that in the neuropraxia, which is the mild form of affection, there is only affection of the myelin sheath, there's just compression of it. And then inside here there is, in the axonotmesis, in these two, there is involvement or disruption of the nerve fibers, yet within the epineurium, there's preserved epineurium. Here there is a total disruption of the nerve with the epineurium and the perineurium, and this is either severed with complete transection of the nerve, or it is replaced by abnormal neuroma, a focal saccular dilatation of the terminal severed part of the nerve. Now in neuropraxia, pathologic changes in neuropraxia involve only the myelin sheath, just like I said, and it's important to distinguish between these entities because the management will be altered totally. So, in the case of neuropraxia, the patient has an excellent prognosis. He will regain the normal neuronal function. On MRI, the nerve will show abnormal T2 hyperintensity with mild enlargement, yet with a preserved neuronal pattern and preserved fascicular pattern. The causes include a mild stretch or mild forms of nerve entrapment, such as the tunnel syndromes, and compressive effects, mild compressive effects by space-occupying lesions. All these causes can cause axonotmesis by a further moderate to more severe degree of affection or compression of the nerve. Now, this is an example of, I'm going to show you some examples of neuropraxia. Now, here, this is a case of thoracic outlet syndrome. We've got a bony cervical rib, which is abnormally communicating with the first rib. This is the MR neurography. Now, of the left brachial plexus, there is accentuated enhancement and enlargement of the nerve, together with an abnormal orientation. It is kinked. This is not the normal orientation. As we mentioned, we have to deal with all the points related to the assessment of the nerve. Another example, as I mentioned before, now this is a knee trauma. The patient has, as we can see, there is a malocontusion here, which was associated with an element of periosteoitis. This has affected the course of the common peroneal nerve, which in this case I'm going to show you the normal. Now, on a fat suppressed sequence, this is the common peroneal nerve. It is small, it is dark, but here we can see that it is bright. It is even up to the color, or sorry, the intensity of the vessels. Another example of the carpal tunnel syndrome. Now, this is the normal median nerve. And as we can see, first of all, the fat planes which are seen underneath the flexor retinaculum are preserved. There is no crowding of these internal structures here as regards the flexor tendons and the median nerve. Here, due to the crowding of the structures and the constriction of the space underneath the flexor retinaculum, there has been compression on the median nerves. We can see we can see the fascicles here, but it's enlarged, it's flattened, it's compressed in comparison to the normal. This is just an example of DTI. There have been attempts performed to assess the carpal tunnel syndrome when there is clinical suspicion, yet not mounting to actual MR abnormalities. Sometimes according to the preliminary results, DTI is playing a role here. First, by comparing it to an age-matched control. This is the normal median nerve in terms of nerve fiber orientation, size, color hue. There is alteration in the color. It is assessed at various segments or various levels. to assess again the flattening, if there's disruption of the fibers or there's alterations in the color hue, to verify the degree or the extent of compression. This is another example of tarsal tunnel syndrome. In tarsal tunnels, there is, I'll just put the other images, okay? Now here, this is the location of the tarsal tunnel. Again, there's a flexor retinaculum here along the medial aspect of the ankle, with the passage of the tendons. We are talking about the posterior tendon and the flexor digitorum tendon, together with the posterior tibial nerve. Now, here we can see the nerve. Actually, what we are seeing here is there are varicose veins. Now, we've got varicosities here. Here we've got the there are varicose veins, the blue structures, tortuous structures in the surgical, through this surgical approach. These are compressing the normal course of this, the posterior tibial nerve. So this is an indication of surgery in this patient to alleviate this compressive effect. Okay, then we've got the axonotmesis. As we mentioned, there's complete rupture resulting in Wallerian degeneration of the distal segment of the affected nerve, yet within the peri and epinuria, within the confines of the perinuria. The prognosis still remains good, and so it is important to, the prognosis is good, but the rate of axonal regeneration is about 1 millimeter per day, and so this means that he will regain the function of the nerve, but over a longer period of time. So it's important to detect this and to verify this, to be able to follow this up or to track it, instead of putting the patient in the dilemma of other surgical and surgical options. Here we've got زي ما قلت انه التفرقه بتاعت معلش هي الايمج دي طبعا هيزي قوي، بس يعني عايزه اجيب لكم ايمج بس للنورمال ulnar nerve في التي 2 fat suppressed image. يعني هي الفكره انه الاكزونوتميسيس ان انا بلقى يعني simply بالام ار اي اذا قدرت ان انا اعرفها هي برضه اتس enlarged وبرضه there is increased signal، لكن البوينت ان انا بلقى فيها septations internal septations. يعني انا بدل ما القى النيرف، هو المفروض ده النيرف، معلش الصوره مش حلوه، بس يعني هو المفروض ان ده اللي هو النيرف normal location بتاعه behind the medial epicondyle. But here this is a traumatic case where there is anterior translocation of there is anterior translocation of the ulnar nerve, and there is axonotmesis with this septation seen inside the course of the nerve, or the axial section of the nerve. Another example of axonotmesis, but this is an impingement syndrome. Here we can see these muscles are called the piriformis muscles. Now, as you can see here, there's a difference in the muscle bulk between the right and the left. This is definitely hypertrophy. This is a common cause of sciatic nerve entrapment. And this is again here the sciatic nerve on the right side. This is the normal caliber and signal intensity, while as you can see there is the dilated or the enlarged caliber of the left sciatic nerve, the accentuated right signal. Then on a closer look, you can see that there is a septation again within the nerve. Okay, it's difficult, okay, to call this and to definitely call it, but if you see it, you have to raise the possibility of axonotmesis rather than neuropraxia. Another example, we can see also the inhomogeneous pattern of the femoral nerve with also septation seen inside. This was a case of sarcoma the patient was subjected to surgical resection. Either the nerve was affected by the surgical intervention or initially, but I just brought it for the demonstration of the nerve itself and the changes of the nerve in the vicinity of the tumor. This is another example of affection of the femoral nerve. Now here by vascular malformations. Now this patient can come for assessment of the vascular malformations. This is the main concern of the patient. The patient is complaining of dull aching pain or neuropathic pain. And we have to assess if it's related to the course of the nerve. We have to assess its effect, its implication, or its, if there is any form of nerve affection. In neurotmesis, this is the most severe type of injury, and it refers to the complete severance of the nerve. The functional loss is complete. And this patient won't regain function or neural function again. There have been attempts, of course, here with stem cell therapy, but they are still under trial. As we can see, there is Wallerian degeneration and loss of this terminal distal part of the nerve, and it is replaced by the conglomeration of fibrous tissue and severed nerve endings forming the neuroma. Now, in the acute stage of neurotmesis, MR neurography can directly show the nerve discontinuity and the gap. It is important to verify the location and the gap of this, and the size of this gap in the affected nerve. Because if we are talking something pre-ganglionic, the management differs from if it's post-ganglionic. This is according to the location. And then, especially in the brachial plexus and the lumbosacral plexus, where we can see the ganglia. And then there's another point, and the gap is important because either the patient will need the nerve grafting or advancement of the nerve according to the size of this gap. Here there's an example. Now this, we can see the normal brachial plexus with the continuity of the nerves. Here we can definitely see there are no nerve roots, and there's the edema and the enlargement of the proximal part. This gap has to be assessed and has to be verified in the record. Another example here, this was a post-ganglionic tear. Well, this is a pre-ganglionic tear where there is a bulging of the nerve root and a pseudomeningeal formation of a pseudomeningeal. Imaging, as this is the point I just mentioned. The regenerating nerve sprouts unable to grow down the disrupted fascicles tangle in conjunction with the peri- and intrafascicular fibrosis to form the neuroma. This is an example of a neuroma. Now this is the severed, this one. This is the severed posterior. This is the severed common perineal nerve, and this is which is dilated and bulky in comparison to the normal posterior tibial nerve. And then this is a coronal MIP. Showing again this saccular dilatation in comparison to the normal posterior tibial nerve. Although MR neurography has evolved into a highly sensitive technique, various diagnostic challenges remain, such as the interpretation of mild T2 hyperintensity of the peripheral nerves as an isolated sign of neuropathy. Mild T2 hyperintensity within the nerve can often be observed in asymptomatic subjects, probably related to magic angle effect, or may represent subclinical neuropathy. Additionally, it could be rather difficult to distinguish between regenerating and chronically degenerating nerves. Now, there is the role of the DTI. DTI allows interrogation of the nerve microstructure and function in addition to providing information on fiber trajectory. Normally, the diffusion of protons along the nerve is 3 times higher than across the nerve because of restrictions posed by the myelin sheath, and this is the phenomenon we know as anisotropy. Thereby, DTI allows nerve tractography, and again we can quantify the apparent diffusion coefficient, the mean diffusivity, and the fractional anisotropy. Now, in a case where there is affection of the nerve or injury of the nerve, there will be edema. So there will be a rise, simply there will be a rise in the ADC value and a decline decline in the fractional anisotropy. With progress, with regression of the condition and improvement of the condition, these values, the ADC will begin to decline, reaching back to the normal values, and the fractional anisotropy will go on to the opposite to increase. Now this is an example of a case. Now here we've got an axonotmesis, and on follow-up, this is the diffusion-weighted WIPS image, and on follow-up we can see that initially there is the faint appreciation of the nerve fibers, and then gradually they are regaining their normal signal characteristics on the diffusion-weighted images, and then furtherly by quantifying the ADC values, it started by 1.6, which is high, denoting edema. Then it furtherly became 1.4 till it ended by 1.03 times 10 to the power negative 3 millimeters square per second. And finally, this was the outcome. I'm going to just show you some illustrative cases quickly. Now, this is a 36-year-old male patient complaining of this aesthesia, which is a whiplash pain. Means at the perineal and anal regions. Patient took analgesics, yet pain persistently recurred. We are talking here now, according to this clinical presentation, a clinician usually suspects a pudendal nerve entrapment. This whiplash sensation at the perineal and anal regions raises the suspicion of pudendal nerve entrapment, which may commonly be entrapped at the level of the ischial spine, or through the Alcock's canal along the ischial tuberosity, its course along the ischial tuberosity. Now, in this case here, we can see down here, this is the normal pudendal nerve. You can barely see it, or okay, it's seen as a thin, relatively hyper-intense structure coursing along the medial aspect of the obturator internus muscle. And then, as we can see here, this is a more frankly seen enlarged nerve. Now again, we are talking about a small nerve. I'm not going to see it like the sciatic nerve. It has to be, you have to be sensitive to what's normal and abnormal to be able to call it. And in this case, the patient would benefit when we delineated the cause. There is preferential neuritis here in the pudendal nerve from the targeted therapy, which is the CT-guided medication injection. Another case, a patient with a foot drop. Again, from these cases I told you earlier, the 52 cases I told you earlier, about 3 or 4 of them were came presented with foot drop. Now there are different causes and different levels of foot drop. This could start by a disc prolapse impinging the nerve root, say L5 nerve root, and then along the course of the sciatic nerve down to the perineal nerve, affection of the perineal nerve. Now here, this is an example. It's a rare case, but it was actually seen. This is a type of internal hernia. It's a sciatic notch hernia. There is internal herniation of bowel, okay, seen at this plane. Now this is the CT study of the patient. You can see bowel herniating abnormally into the gluteal region. This is affecting, of course, the course of the left sciatic nerve. It is compressing it to the extent of impaired function, which led to the patient's symptom presentation of foot drop. This is another case of, this came to us with a gunshot wound. He received to the lateral aspect of his thigh. Now, this was the course of the bullet. It was surgically removed, but then this is the sciatic nerve. Of course, now, this is the normal sciatic nerve. It's okay, it's a large nerve, but it's not that large. Okay, so this is an abnormal sciatic nerve. Okay, now this is the pattern of a neuroma. There is a neurotmesis, there is a complete severing of the sciatic nerve, with resultant neuroma of the sciatic nerve, the saccular dilatation and enlargement of the distal end of the sciatic nerve at the site of the injury. And then this is the secondary sign with the muscle denervation, with the resultant foot drop, implication of the tibialis anterior and the peroneus longus muscles. Then we got another case here. This is a known case of non-Hodgkin lymphoma with right upper limb weakness. Okay, typically we would be thinking of lymph nodes that have a compressive effect, maybe, but we can see here that there is enlargement of the nerve, okay, and it's enhancing. This is a post-contrast, sorry, this is not a post-contrast image, this is a stare. It's enlarged and it shows inhomogeneous bright signal. This is the post-contrast sagittal showing the section, an axial section of the nerve itself, how bulky it is and homogeneously enhancing. And then this is the diffusion weighted image. Now, there is a preferential diffusion restriction here. Okay, along this course. What's important here is that you don't call diffusion restriction from a diffusion weighted image alone. You have to see diffusion restriction on an ADC map, because this is the same pattern of neuritis. It's the same pattern as a signal intensity on a diffusion weighted image. So accordingly, when you correlate with the ADC map, this actually had a very low ADC value, these selected nerve roots, which was about 0.4, 0.5. So this is with cellular packing, because when we're talking about neuritis, we are talking about facilitated diffusion due to the edema, and so there will be a higher ADC value that may reach about 1.4, 1.6. So this is definitely not neuritis. This was lymphomatous infiltration of the nerves. Another case with agonizing right neck pain and right upper limb weakness. I showed you this case earlier with the malignant nerve sheath tumor, and then again on MRI the focal diffusion restriction, and this is its DTI. Now there is a disruption again. There is a disruption of the nerve roots, and then there is abnormal and heterogeneous signal with the color hues of the severed fibers, and there is gapping here. There is gapping here between the nerve roots and the distal portions of the nerve by the infiltrative lesion. This is another case with abdominal distension and discomfort. What do you think this is? Yeah, MR neurography. أكيد مش هجيب حاجة. Neurofibromatosis, plexiform neurofibromatosis. هي مش هي دي الايشو، هو عمل الابdominal and it raised the possibility of retroperitoneal neurofibromatosis. And then the patient did his study. We can see the diffuse enlargement of the nerve roots and the fibers later on. And then this is his dorsal, same patient. There is implication of the saccular implication and the enlargement of the dorsal nerve roots. The DTI, where there is disruption of and alterations in the color hues of DTI. Here is this will be the role of a whole body MRI in this certain patient, because you want to see the extent of involvement from head to toe with the associated soft tissue involvements. This patient is complaining of cyclic left sciatica. We can see that this is, what is this? Okay, يعني we can think of مثلا يعني a schwannoma, but then this patient removed this lesion, okay, surgically, and this is what the patient actually had on her pelvic MRI. لا قولي لا endometriosis and extrapelvic endometriotic deposit على النيرف. طبعا this is rare طبعا، بس انا قصدي يعني بالظبط مش هتتقال يعني كدايجنوزس، لكن it actually turned out like this on surgery. ولما اتعمل بعد كده هي it's cyclic pain، ولما اتعمل الام ار اي بقى بعد كده على البلفس كان في endometriotic implants. To sum up, MR neurography has come a long way in the past 2 decades. Excellent depiction of 3D and nerve anatomy and pathology is currently possible. Further technical developments in diffusion-based nerve and muscle imaging, whole body MR neurography, and nerve-specific MR contrast agents. This is a nice contrast agent. It is also under trial. It is not used as, it's not still FDA approved, the gadol fluoride. Now, it selectively accumulates in the nerve fibers that have undergone Wallerian degeneration. And only the nerves that are affected, there is injury, will enhance. And this enhancement is sustained. It will be entrapped within the nerve. يعني لما يجي يعمل follow up هلاقيها برضه لو هو لسه في injury. فبالتالي with the follow up study, if this regresses, this enhancement regresses, this means that it's losing the gadol fluoride, and that this means indirectly that there is remyelination. So this could play a main role in adding more depth, sensitivity, and specificity to the study in years to come. Thank you very much.